Welcome to the next talk. Today we're going to be focusing on upper limb musculoskeletal radiology and having a look at some common cases that you may come across. In particular, we're going to focus on how best to manage these cases, especially in the emergency setting. So what are our learning outcomes? Well, we're going to be identifying bony anatomy on plain film radiographs. We're going to be describing long bone fracture and then finally looking at some common musculoskeletal upper limb pathologies and orthopaedic presentations at the shoulder, elbow and wrist, and how best to manage these, especially in the emergency setting. And this is by no means a comprehensive review of the upper limb pathologies that could present, but is there to give you an idea of some of the common ones that you may come across. The next step is identifying what type of fracture is present. And as you can see over here, there are many patterns that are described depending on the mechanism of injury and whether the injury is a high or a low injury, as well as the type of bone which the injury has gone through, whether that be weak, frail and osteoporotic bone versus stronger and younger bone. Now, looking at this, we can see the key types of fractures are a transverse fracture, which is straight across at 90 degrees to the long axis of the long bone. The other options are an oblique, which, as the name suggests, is at an angle to the long axis of the long bone. And the oblique fracture can be either short or long oblique. Short oblique, which is shown here, and long oblique, as I'm showing with the cursor, can be a much longer diagonal fracture pattern. The next type of fracture is a spiral fracture, and on a plain film radiograph, which is a 2D image of a 3D structure, it can look very similar to an oblique fracture. But actually, if we looked at it in 3D reconstruction, we would see that it's actually kind of like a helter-skelter pattern rather than a simple oblique fracture. And other fracture types are the comminuted or multifragmentary, representing a higher energy fracture. This is where there are multiple fragments visible. Now, the other two fracture patterns shown over here, especially the green stick one, represents fracture patterns that are normally seen in pediatric fractures. That's due to the type of bone that is present, which tends to be more elastic than adult bone. And therefore you get these incomplete fracture patterns where only one cortex of the bone may be affected and the other cortex may be intact. But for adult fractures, this is not as relevant. So once we've identified step 2, what type of fracture it is, we then need to comment on the different characteristics of the fracture. And these can be described by different mnemonics, one of them being BART. This looks at 4 key elements of how the two fractured ends of the bones relate to each other. So taking this in turn, the first one, B, stands for bone length. Now, once a bone fractures, the two ends of the bones are mobile and are subject to being acted upon by muscles that cross the fracture. Muscles can only contract, and therefore what tends to happen is a shortening of the overall length of the bone due to the bone ends being shortened or pulled over each other. The second is angulation, and this describes how one fragment of the bone distal to the fracture relates to the bone proximal to the fracture, and it may be angulated, which can be described in degrees. The third is the rotation. Now, it's difficult to comment on rotation on plain film radiographs, which are 2D images, but there's certain clues that we can look at, and especially certain bony prominences, which may be visible or may not be visible depending on if the bone has rotated. And finally, we look at translation, and this looks at the medial lateral movement of the distal fragment of the bone end as described relative to the proximal. And you can have, as you can see in this image over here, about 50% translation medially of the distal bone fragment compared to the proximal, or you can have 100% translation where both bone ends are no longer touching each other, or more than 100% as well. When we have 100% or more than 100%, this can be termed an off-ended fracture. In other words, where there's no contact between the fractured bone ends at their fractured surface. So this is the third step, looking at the displacement of the two ends of the long bone at their fracture. So let's take an example. Assuming we've guaranteed that this is the correct patient, the correct image, the date, and also that we're happy with the technical quality, which we wouldn't be in this instance as we can't see the entire long bone. Step one is to identify which bone and whereabouts in the bone the fracture is. So as we can see, this is the femur, and the fracture is in the long tubular part in the middle, which is known as diaphysis. This is a diaphyseal femoral shaft fracture. Step two is to identify what type of fracture it is. And as we can see, the fracture line runs approximately perpendicular to the long axis of the long bone. As we said, that is a transverse fracture. Of course, we'd need a lateral view, as we do in all cases, to rule out that this fracture is not running obliquely in the lateral view. But as far as we can tell, this is a transverse fracture. Step three now is to look at the displacement of the fractured ends, looking at our BART mnemonic. So let's start with B, the bone length. As we can see, there is a tiny bit of overlapping, very minimally. So this would be a minimally shortened fracture. The second part of it is the angulation. And as we can see, the distal bone fragment compared to the proximal is roughly in line. There seems to be very little angulation of the distal compared to the proximal end. And therefore, this is minimally angulated, if at all. The third thing is rotation. And again, that's difficult to assess on this view, but there does not seem to be any apparent rotation visible on this one view. And finally, the translation, the movement medially laterally of the distal bone end compared to the proximal. And as we can see, the proximal shaft is certainly not lined up with the distal shaft. The distal bone end has moved medially almost 100% compared to the proximal end. And there's little, if any, overlap of the bone ends or touching. So this would be 50 to 100% medial translation. Therefore, we can describe this as a mid-shaft transverse femoral shaft fracture with minimal bone shortening, minimal angulation, minimal rotation, and 50 to 100% translation. Let's take another example. Again, assuming that we've assessed the technical quality of the film and we have the correct patient, first step is to identify which bone we're looking at and also whereabouts in the bone the fracture is. As we can see, this is the radius and ulna and the wrist over here distal to it. We can see the fracture over here in the distal radius at the metaphyseal junction. So this is a metaphyseal distal radius fracture. The next thing is to identify what type of fracture pattern we have. On the lateral view, you can see again the fracture pattern is almost at 90 degrees to the long axis of the long bone. Therefore, this is a transverse fracture. We can also comment that it's extra-articular, as the fracture line does not seem to be extending into the joint. Now the third thing, again, is to comment on the displacement. Let's look at B, bone length. We can see there is some overlap of the bone ends over here. As we can see, that is the fracture of the proximal fragment, and that is a fracture of the distal fragment, and there's some overlap, and therefore there's some bone shortening. Looking at the angulation, we can see that this is the distal aspect of the radius, and it seems to have tilted backwards, and therefore this is dorsally angulated, dorsal referring to the back of the hand. Looking at rotation, again, it's difficult to comment, but there does not seem to be any obvious or apparent rotation. And again, looking at translation, there's still pretty good contact between both bone ends, maybe a little bit of movement, and so there's probably some minimal translation. So this is a metaphyseal or distal radius fracture, which is transverse and extra-articular, with some bone shortening, dorsal angulation, minimal rotation, and minimal translation. And finally, let's have a look at this last example. So, first step is, which bone is this, and which part of the bone is fractured? We can see this is the femur over here, and this is the tibia here with the fibula next to it. So therefore, this is a tibia and fibula fracture, and this is again in the long tubular aspect of the tibia and fibula as well, and therefore this is a diaphysis or diaphyseal tibia and fibula fracture. So the next step is to comment on the type of fracture pattern. As we can see, there are multiple fragments over here, and therefore this is described as a multifragmentary or comminuted fracture pattern. The third step now is to comment on the displacement. Looking at the bone length, well, we can see there's overlap of the two bone ends of the fibula, and therefore there must be some shortening, even though it's difficult to appreciate that in the tibia. Angulation, well, again, the axis of both the proximal and the distal bone end seem to be fairly well maintained, so there may be some minimal angulation medially, however it's not marked. Rotation, again, it's difficult to comment on this 2D image, but there doesn't seem to be any obvious rotation. A good way to assess that would be to see the ankle joint and see if that's rotated in comparison to the knee joint, which we can see. And finally, we're looking at translation. And again, we can see the proximal end of the tibia and also the fibula in comparison to the distal end of both of those bones. There's significant translation, certainly off-ended when it comes to the fibula, and most likely off-ended when it comes to the tibia as well. So this is a proximal third diaphyseal tibial fracture with a multifragmentary or comminuted pattern with bone shortening, minimal angulation, difficult to assess rotation, and off-ended or over 100% translated. So that's a rough idea as to how to interpret these musculoskeletal X-rays. Let's have a look at some examples at specific joints in the upper limb. Let's start with the shoulder. As we can see, this is a normal anterior-posterior or AP shoulder X-ray or radiograph. Now, of course, with all orthopedic musculoskeletal imaging, we want to look at two views, and therefore we'd want to look at a lateral view. But let's identify some anatomy over here. Well, we're looking at the shoulder from the front, and we can see, therefore, this is the left shoulder. This bone over here is the clavicle, or the collarbone, and this is the lateral end of it, where it articulates with the acromion, which is a part of the shoulder blade or scapula. Another part of the shoulder blade or scapula is the coracoid, circled over here, and this projects anteriorly from the coracoid, from the shoulder. As we can see, the lateral end of the shoulder ends in the glenoid fossa, and this is the articulated surface with the spherical head of the humerus. So those are the key parts of the shoulder X-ray. We can see the ribs over here medially, and it's important to look at those, especially in patients with high energy injuries, as you can see rib fractures here sometimes. And we can see the proximal humeral shaft here as well. And it's important to assess that as well, as there may be fractures over here, especially in the proximal humerus in elderly patients. Now, let's have a look at the lateral. As we can see, we've got the acromion here again, which articulates with the lateral aspect of the clavicle or collarbone. we have the coracoid process over here, which projects anteriorly, and therefore these two form a Y shape. In the middle of that Y shape, you should have the head of the humerus, and it should sit over there. And you can see the glenoid is over there as well. So we can see the head of the humerus is articulating the glenoid on the lateral view, sitting between the acromion and the coracoid of a Y, and therefore this is a normal lateral X-ray of the shoulder. So let's have a look at a case. We have a 25-year-old male with a high body mass index of 33. He sustained a fall on the outstretched hand, and he complains of right shoulder tenderness, and also notice a change in the contour of his right shoulder. So of course you want to go and take a history from the patient more thoroughly, but assuming that's done, let's fast forward and have a look at the examination. And the first thing is having a look at the patient. As we can see over here, the left shoulder shows a normal contour of the shoulder. This is formed by the deltoid muscle over here, which gives that contour, especially superiorly. On the right hand side, we can see that that contour is different to the left and shows a more squared off or pointed appearance, known as squaring of the shoulder. This is because the normal contour given by the deltoid has been lost, because the shoulder is dislocated. The other option is wasting of the deltoid muscle, but that's much less common. Sign 2 is external rotation, abduction, and immobility. Now, the shoulder can dislocate in various directions, anterior being the most common. And depending on the direction it dislocates in, will influence the position that the arm is in, as different positions put the shoulder at greater risk of dislocating in different directions. An external rotation and abduction is associated with an anterior dislocation and may present with a patient such as the one in this picture, holding his arm in that position. So, of course, we're going to get a plain radiograph, and as you can see, this is what's shown in that patient. So let's identify the anatomy. We can see the clavicle hair, the acromion hair, the coracoid hair, and the glenoid fossa hair. Now, normally, as we can see, the humeral head hair should sit where I'm drawing the circle here, but it's certainly not there. It's dislocated, but we now need to work out whether it's dislocated anteriorly or posteriorly. And we need to get a lateral view to look at that in more detail. So looking at this lateral view, we can see the glenoid is highlighted in red in the center, and the humeral head is certainly not articulating with that, but is actually moved anteriorly in relation to the glenoid towards the coracoid. Therefore, this is an anterior dislocation of the shoulder. Now, looking at that in a little bit more detail, this shows a diagrammatic picture. So the next step is we've identified what the pathology is. We now need to think about how to manage this, especially in an emergency setting. Before we do that, however, we need to consider a neurovascular assessment, especially as one of the nerves in particular, the axillary nerve, is placed at risk in shoulder dislocations. As you can see over here, the axillary nerve runs very close to the glenohumeral joint, and therefore anterior dislocations in particular may put pressure on that. Now, the axillary nerve, as shown in this diagram, gives sensory branches to supply the area on the proximal and lateral aspect of the proximal humerus, also known as the regimental badge area, as shown over here, and also gives motor supply to supply the teres minor muscle and the deltoid muscle. Now, it's difficult to test motor function in a patient with a shoulder dislocation, as it will be painful, and therefore what we have to test is the regimental badge area for sensation, and it's critical to do this. In addition to doing that, however, we're also going to be doing a full upper limb neurovascular assessment, and for this in more detail, please have a look at my upper limb neurovascular assessment video. But very briefly, we want to test the median, radial and ulnar nerves, both the sensory and the motor distributions. As we can see, we're going to touch on the dorsum or back of the hand between the thumb and the index finger to test radial nerve sensation. We're going to test the tip of the index finger on the palmar side of the hand for median nerve, and the little finger on the palmar or the dorsal side for the ulnar nerve. Testing the motor function, we're going to ask the patient to straighten their hand to test the radial nerve, I'm going to ask the patient to make an OK or a 0 sign to test the median nerve, and also ask the patient to make a star-shaped sign to test the ulnar nerve. These three key areas. Assuming those three are absolutely fine, we now need to think about how we're going to put the shoulder back in the joint. But before we do that, as with any orthopedic injury, it's important to follow the 4R principle and think about resuscitation as a first R, as a shoulder dislocation may be part of a larger injury or multiple injuries, which may be more urgent or pressing to attend to. Assuming that's not the case, and we've done a neurovascular assessment, we now need to reduce the shoulder. That means putting the shoulder back where it's supposed to be, articulating with the glenoid fossa. We can do this in a variety of ways, either outside of the operating theatre or in the operating theatre. But it's going to require analgesia, and therefore we give the good patient good analgesia to ensure that their muscles are as relaxed as possible, as this is key to ensuring that we are able to reduce the shoulder. Analgesia can be in the form of Entonox, Oromorph, or can be sedation as well, which will require monitoring, so then it needs to be done in the emergency department resuscitation area. The third option is to do it in the operating theatre under general anaesthetic, but there are risks of doing that, and therefore it's preferable to do it in the emergency department if at all possible. Now, there are many manoeuvres described for relocating a shoulder, but it's important that whichever manoeuvre we use, we need to have good traction to disimpact the shoulder and increase our chances of relocation. And therefore, this technique of having a bed sheet around the patient to provide countertraction and someone pulling in a controlled manner on the arm is a favoured option. Once the shoulder has been reduced, a sling can be given for comfort, and the patient can be given a fracture connect follow-up within the next week or so that they can begin the range of motion exercises, especially for those who have only sustained a pure dislocation and it's their first time. For those who have multiple dislocations, they may need to see a shoulder specialist. However, it's important to be aware that not all shoulders can have reduction performed in the emergency department. And these are two cases where it certainly would not be wise to attempt this. These show not just pure dislocations, but fractures as well. So fracture dislocations of the shoulder should not be reduced in the emergency department as a rule of thumb. As we can see on the right-hand side, we can see the humeral head here again is dislocated anteriorly as it is not articulating on the glenoid fossa. But this big fragment here is greater tuberosity, which is fractured off. And therefore this represents analogous to a large rotator cuff injury and will most likely need some sort of operative intervention depending on patient factors. This large greater tuberosity fragment as well may impede reduction, and therefore this would most likely need to go to the operating theatre to have a reduction. This on the left hand side shows 2 or 3 fractures of the proximal humerus, and as you can imagine, attempting to reduce this in the emergency department would just cause you pulling on the humeral shaft, which is not attached to the proximal humerus, and therefore will not be able to control the proximal humerus and reduce it. Therefore, this should not be attempted in the emergency department. Now, 2 of the key caveats to making this a more urgent procedure is neurological compromise and, even more importantly, vascular compromise, which would certainly make this more urgent. But these should both be reduced in the operating theatre and most likely with an open reduction, which means that you can clearly see the fragments before reducing. So let's move on. What about this? Well, again, this is a AP of the left shoulder. Now, as you can see, we have the clavicle hair, the acromion over here, the coracoid hair, and at first glance, the glenoid seems to be articulating with the humeral head on both the left and the right images over here. But how the left and the right images look different to each other, especially with regards to the humeral head and the contours. On the left hand side, the humeral head seems to be articulating nicely with the glenoid, and we can see the greater tuberosity as well. On the left hand side, we can see that the greater tuberosity, which would be over here, that contour, is not there anymore. And therefore this suggests that this is rotated, the humeral head is rotated, at least 90 degrees, if not more. For it to be like this, it's most likely this patient has suffered a dislocation, a posterior dislocation, rather than anterior. As you can imagine, these are quite tricky to pick up and can easily be missed, and therefore it's absolutely crucial to get two views, and if required, a CT scan as well, to ensure that the humeral head is congruent with the glenoid fossa. Causes of posterior dislocation are classically electrocution or seizures, and therefore it's important when we assess these patients to look at the whole patient and treat the causes of the shoulder dislocation or the fall, as well as the shoulder dislocation. This is often known as the light bulb sign, as the humeral head looks symmetrical, which it normally wouldn't, as we would normally have the greater tuberosity contour over here. The reason it looks symmetrical, as we said, was that internal rotation of the humeral head. But to the quick glance, it can look like it's in joint, and therefore it's important to really interrogate these plain radiographs. A lateral radiograph would be very useful in that instance as well. So again, managing these is similar to the anterior dislocation. We want to first focus on the resuscitation aspect of it before we focus on the reduction. We'd do the same neurovascular assessment as we did before, although it's less likely that the axillary artery has been compromised. And again, with reduction, we need to be very careful here, as posterior dislocations can be caught up on the edge of the glenoid, and therefore excessive force or traction can actually cause a fracture of the humeral head. Therefore, it should be attempted by an experienced person and may well require a CT beforehand to see whether there is a risk of the humeral head being fractured before attempting. It would be completely reasonable to perform these in the operating theatre if there was no one comfortable or competent to do this in the emergency department. Afterwards, the management is similar: give a sling for comfort and a fracture clinic follow-up for this patient to begin early range of movement exercises. It's important when the sling is given to ensure that the patient continues to take their arm out of the sling and move their elbow and their wrist as well, as these can become stiff if the person holds their arm in a sling religiously. And let's look at this final example. As we can see, again, we've got the clavicle here, the acromion over here, coracoid projecting anteriorly, the glenoid, and the humeral head. And again, on first glance, the humeral head is articulating with the glenoid as expected, with the normal contour of the greater tuberosity here as well. And therefore, the glenohumeral joint has no pathology visible. But if the patient is complaining of pain, it's important to look at the entire shoulder X-ray. And actually, if we look more closely, we can see that the lateral end of the clavicle is not articulating as it normally should do with the acromion. Therefore, this is an ACROMIOCLAVICULAR dislocation. Now, again, we'd want to take a full history. We've already taken imaging, assessed the neurovascular status, and then think about how we're going to manage these injuries. Now, these are called by fall onto the shoulder, and if we really want to test this, although it's not recommended as it's most likely painful and the diagnosis can easily be ascertained from the X-ray, we could do a scarf test, which is where we flex the patient's shoulder to 90 degrees and again ask the patient to touch with their hand the opposite shoulder. As we adduct the shoulder here, it will place more stress on the acromioclavicular joint, which will cause pain. But as we said, we can see the diagnosis clearly on the X-ray, and therefore it would not be advised to put the patient through pain when it's not going to give us any further information. Most of these are treated non-operatively with a broad arm sling, as this gives support to the elbow and support to the arm, and early mobilization as well. Some of these can be treated operatively depending on the severity of this and depending on the symptoms, although in most cases we start with non-operative treatment. So those are some of the main shoulder pathologies you may come across. Let's move on now to looking at the elbow. Now with elbow, it's important to bear in mind the Salter-Harris classification. And whilst classifications are sometimes not useful in orthopedics, this is certainly one of the important ones that it's important to be familiar with. And thankfully, there's an easy way of memorizing it. Saltera's classification looks at fractures in and around the growth plate, and therefore applies to pediatric fractures. Saltera's type 1 is where the fracture is straight across the growth plate. Saltera's 2 is where the fracture straight across and actually goes slightly above and therefore into the metaphysis. Saltera's 3 is the opposite, through the growth plate and into the epiphysis. Saltera's 4 is where it goes through the metaphysis and the epiphysis. And Saltera's 5 is a crush injury with erasure of the growth plate. This can be memorized here with the mnemonic SALTER as shown below. The reason why it's so important when it comes to the elbow is because of this. Now, elbow X-ray interpretation, especially in pediatrics, can be very difficult due to a number of things. Firstly, there are numerous ossification centers which become visible on bony plain radiographs as the child grows, and therefore an estimate of a child's age can be obtained from the elbow and the presence or lack of ossification centers. Children who have elbow injuries and fractures may not always be apparent, and therefore we may have to look for not just bony signs but soft tissue signs as well. So as we can see here, there's an anterior and a posterior fat pad which sit in the coronoid and the olecranon fossa respectively. If there's a fracture around there, sometimes we can get swelling and even some blood which goes into those fossae and can push the fat pad out. And there's different densities of blood and swelling fluid compared to the fat can give different soft tissue signs on the pediatric elbow. So, looking at this in more detail on an X-ray, we see the anterior fat pad here. And if we can see this, it doesn't mean that it's pathological. In fact, it can be normal to see the anterior fat pad. Seeing a posterior fat pad, which we can't see in this image, is almost always pathological and signifies some injury of some description. As we can see, the radial head is over here, the olecranon is here, and whilst this looks like a fracture, this is again the normal growth plate and normal ossification of these structures. One of the key lines that can help us with interpretation is the anterior humeral line. This runs, as suggested, over the anterior humerus straight down and should go through the capitellum and trochlea on the lateral view, normally in the middle third or anterior third. As we can see, there are various ossification centres which can be remembered with the mnemonic crito or critol for the lateral epicondyle. And therefore, if we can see these ossification centres, we know the child must be at that equivalent age as seen over here. So on this, we can see that there's a capitellum here, there's a radial head ossification centre, and medial or internal epicondyle, a trochlea as well, seen over here on the AP view, an olecranon, and then we go look at the external epicondyle, which is just becoming visible. And therefore we know this child must be between 9 and 11 years old. So let's have a look at a case. We have a 5-year-old child who presents to the GP with elbow pain, and the parents reported a fall at home 4 days ago. So what are our differential diagnoses? Well, we want to take a more full history, but there are some concerning features in this short history. With children, we always have to be aware of safeguarding and our duty to safeguard them. And therefore a delayed presentation, especially of 4 days, may be worrying and warrants further investigation and questioning. We always have to be aware of non-accidental injury, and there's certain red flags that can alert us to this. These include a delayed presentation, as in this case, an inconsistent history, multiple injuries, multiple emergency department attendances, signs of neglect, lower limb injuries, especially in those patients that are non-ambulatory or before walking age. And there are other social circumstances such as being in foster care or being with a non-biological carer, as well as the pattern of injury that the child presents with. Assuming in this case we've looked through this and discussed with our safeguarding lead and we're not concerned about this, let's have a look at the image. As we can see over here, we draw our anterior humeral line over here. It does not go through the capitellum and trochlea here, and therefore there's some abnormality on this X-ray. We can see the radius is there visible. The ulna is visible there as well. If we look closely, there's this black shadow here, the posterior fat pad sign, with a different density here. Therefore, there is some pathology going on. If we look more closely, there's a fracture across here, or a supracondylar fracture. This child, therefore, has a supracondylar fracture. Now, we can classify supracondylar fractures depending on their severity, and this can help us decide as to the management of them. The Gartland classification is useful and looks at how displaced the supracondylar fracture is. The Gartland 1 is an undisplaced supracondylar fracture with just a fracture line. This can be treated non-operatively in a cast, with a child in a cast at 90 degrees or more for a week or a few weeks depending on their age. Type 2 injury is where the posterior cortex is intact, however the anterior cortex is not, and therefore there's displaced anterior wall of the supracondylar fracture. And the Gartland type 3 injury is where there's an off-ended or the posterior hinge has been lost as well, and this is treated operatively type 3. Type 2s can be treated non-operatively or operatively depending on the specific injury. So why are we concerned about this? Well, as always, we want to worry and take a detailed history and also take a full neurovascular examination, which can be more challenging in children. Again, we want to worry about resuscitation if this is part of a high energy injury, but assuming it isn't, with a neurovascular assessment, we modify this to make it easier to do in children. This can be done with the rock, paper, scissors to assess median radial ulnar nerves. Rock assesses very globally median function as it tests the flexors. Paper tests the radial nerve function as it causes extension at the metacarpophalangeal joints. And scissors tests the abduction, adduction, and therefore focuses on the interossea, which is supplied by the ulnar nerve. In addition, it's important to do the OK sign as well, which tests a branch of the median nerve, which can be at more risks in supracondylar fractures. And this is why. With supracondylar fractures, we have the brachial artery and the medial nerve, which run anteriorly. And therefore, one of the fractured ends can tent this or put pressure on both of these structures. With the median nerve, this will most likely affect the anterior interosseous branch, which will compromise the function and be able to make an OK sign. And any vascular compromise is certainly urgent, if not emergent, to deal with. So what do we do? Well, if the patient has any neurovascular compromise, they will need to go to the operating theatre. As we said, Gartland 1 fractures and most Gartland 2 fractures can be treated non-operatively in a cast, casted in 90 degrees, with follow-up to ensure that the fracture is healing well. Some Gartland 2 and all Gartland 3 fractures need an operation. Now, the timing of that operation depends on the neurovascular status. If the patient has a normal neurovascular status, then the patient will need to go to theatre, but it's certainly not urgent or emergent. If the patient has a pale and pulseless hand, this suggests that the brachial artery has been compromised and that there's not sufficient collateral flow to be able to perfuse the hand, and therefore this is a vascular emergency. The patient needs to go to the operating theatre as a matter of emergency as soon as possible, even in the middle of the night. If the patient has a pink and pulseless hand, then it suggests that there may be some spasm or compression of the brachial artery. However, there's still some perfusion of the hand as it is pink, and this may be through collateral perfusion, or maybe that there's still some blood flow through the brachial artery. Therefore, this patient does need to go to the operating theatre urgently, but certainly not an emergency, and therefore this would be a first on the operating list rather than in the middle of the night type case. This is an example of a Gartland 3 fracture. This would certainly need to go to the operating theatre, especially as this proximal bone fragment, as you can imagine, may be tenting or causing irritation to the brachial artery and or the median nerve. And in the operating theatre, this is an example of what may happen. What we do is reduction, getting the bones back in the correct alignment, and then pinning them there with K-wires, which will come out several weeks later once the fracture is healed. The patient will then be placed in a cast after having this K-wiring done, and will be followed up in the clinic to ensure that the fracture is healing correctly. So let's have a look now at the forearm and the wrist. As we can see, starting off with X-ray interpretation, this is an AP and lateral radiograph of the right distal radius and wrist. There doesn't appear to be any fracture here, and therefore this is a normal X-ray. Now there are certain lines and degrees that we look for on the radius, and this can help as to whether we need to perform an operation for patients with distal radius or wrist fractures. Very briefly, it's a rule of 2s and 1s. We look at radial inclination. This is the degrees from the horizontal to a line that skirts the radial stylo process, which should be 22 degrees. We then look at radial shortening as well. The distance from that horizontal line, as we mentioned before, to the tip of the radial styloid should be 11 millimeters. 2 millimeters refers to the ulnar variance, which may be variable, but it's the difference between a horizontal line at the distal ulnar and the same at the distal radius. And finally, the volar tilt, which should be 11 degrees. On a lateral radiograph, this joins the distal anterior and posterior radial cortices and looks at the degrees. And this can certainly be altered in those with dorsally angulated radial fractures. So let's have a look at a case. We have a 68-year-old lady who presents to the emergency department after falling over in her garden onto her right wrist. It's now painful and bruised, and she has a past medical history of hypertension and type 2 diabetes. She lives alone, she's independent, and she's right-handed. So of course we want to take a more full history. She's told us the mechanism over there. We know her past medical history, and we know how functionally well she is. We now need to focus on a neurovascular. Once we've done that, as we did before, we're then going to get an X-ray. Now, what can we see on this X-ray? Well, we can see the red dot here, which tells us there's an abnormality. And we can see this is a AP and a lateral radiograph of the right wrist, which shows a transverse, potentially comminuted distal radius fracture with some dorsal angulation, some shortening, minimal rotation, and minimal translation. It is a closed injury, and she's neurovascularly intact, as we've identified from our neurovascular assessment. This is a reminder of how we do the neurovascular assessment in an adult. So, what are the options? Well, any distal radius fracture can be managed with or without an operation. Now, if the fracture is undisplaced, or if we can manipulate it in the emergency department into a better position and place a cast on it, if it stays in that position, it may well be treated without an operation with a cast for 5 to 6 weeks. We would keep an eye on it to ensure it's healing well. If, however, the patient has a distal radius fracture, which is potentially intra-articular, or we can't get it into a better position with manipulation, or there's some neurovascular compromise, or it's an open injury, then we may need to perform an operation. And this depends on patient factors as well as the fracture factors. Operations that we may perform could be percutaneously placing wires, similar to what we did for supracondylar fracture fixation, and then placing the patient in a cast, which you can see here. And the fracture will heal in the position that it is placed in, and the wires can then be taken out several weeks later. The other option is to perform an open reduction, where we place an incision, see the fracture fragments and reduce them directly, and then place a plate over it with screws to hold it there, which will stay forever in the patient. This is the other option as well. As we can see, we have extra-articular distal radius fractures, and they can either have dorsal displacement, which is the most common type, or they can have volar displacement in this case. These are more unstable injuries, as the flexors are stronger, and we'll always want to flex this and displace the fracture fragments. And therefore, more often than not, these will need to have an operation, similar to the one with the plate and screws in the image before. And here's the difference. It depends on the mechanism of injury, and therefore it's so crucial to get this when speaking to the patient, whether they fell on an outstretched hand with their wrist extended or flexed, as this can influence the type of fracture they have. We can get intra-articular injuries, known as BARTONS fractures, and you can see this is a nasty intra-articular comminuted distal radius fracture. You can certainly see it's shortened as the ulna is more prominent, which it normally isn't. And you can see there as well that there's certainly angulation as well. These are most likely going to need an operation, again, depending on patient characteristics. Now, the last thing is looking at the bones of the wrist, which are common injuries that can present to the emergency department. Now, there's different ways of remembering these and different mnemonics. The one I use is, to save lives, the physician helps create treatments. This starts at the trapezium and works our way around the bones of the wrist, of which there are 8. So, trapezium, scaphoid, lunate, triquetrum, pisiform, hamate, capitate, and trapezoid. So let's look at a case. We have a 25-year-old man who presents to the emergency department after falling off his motorcycle at low speed onto his wrist. As you can see a picture of it there, it's bruised and it's painful. Again, we take a full history, make sure there's no concurrent injuries, especially as he's fallen off his motorcycle, albeit at low speed, and ensure we do a full neurovascular assessment before taking some imaging. And as we can see over here, this is an AP and lateral film of the distal radius and an oblique film as well. And at first glance, there seem to be no obvious fractures or abnormalities seen. However, one thing to be careful of is that some fractures are not always seen at day 0 or the day of injury, and scaphoid fractures are notorious for this. Therefore, if we're concerned, we replace the patient in some immobilization, such as a futurosplint splint or comfort, request they take pain relief and keep their arm elevated, and see them back in 1 to 2 weeks in the fracture clinic, where we'd obtain further imaging. At that stage, if the patient pain has resolved, then it's unlikely they had a scaphoid fracture, and they can be weaned out of the futurosplint splint. If, however, the patient's pain is still there, we get further imaging, which may or may not reveal a scaphoid fracture, as seen in this X-ray. You can see there is a scaphoid waist, or what would be known as a midshaft in a long bone fracture. If, however, we obtain imaging 1 to 2 weeks later in the fracture clinic and the patient is still does not show a fracture and the patient still has symptoms, we would then need to obtain an MRI scan. If we saw a fracture, we may need to get a CT scan to characterize the fracture better. But an MRI scan will give us more information, especially regarding soft tissue status as well, if the patient is still symptomatic. For scaphoid fractures, they can be treated non-operatively or operatively, depending on where the fracture is, how old it is, and patient factors as well. So after we've done the neurovascular assessment, we've immobilized them, we've seen them in our clinic, and then we have appropriately obtained further imaging depending on whether the patient's symptoms and what we saw on further imaging on plain X-rays. Now, why are scaphoid fractures so important to pick up and not to miss? It all depends on the blood supply. Similar to neck and femur fractures, it has what we call a retrograde blood supply, and therefore is supplied from distal end proximally. And therefore, if you imagine if there's a fracture over here, the proximal part of the scaphoid will be devascularized as the blood supply is cut off, which is coming from distal, and therefore it may undergo a vascular necrosis, which will certainly cause pain to the patient in the longer term and disrupt their wrist function, which can be devastating, especially for younger patients. Therefore, the more proximal a fracture is, the greater the risk of vascular necrosis. As you can see, the greater the chance the blood supply has been cut off. As I said, there's many different ways to treat scaphoid fractures, and this is an example. This is a percutaneous screw fixation of the scaphoid. It can be placed in the cast for 6 weeks, depending on the position and depending on various patient factors as well. So in summary, we've looked at key shoulder pathologies, including anterior posterior shoulder dislocations, as well as acromioclavicular joint dislocations. We've looked at supracondylar fractures and how important it is to assess neurovascular status, as this will determine how quickly theatre is needed. And we've looked at scaphoid fractures and wrist fractures and how we'd manage them. As I said, this is certainly not meant to be a comprehensive overview, but will give you a good idea as to some of the key and common pathologies you may see when working in the orthopaedic department. Thank you very much for listening. I'm happy for you to post about any subjects you'd like me to teach on, and I look forward to seeing you on the next video. Thank you very much.